It's always great to have such a great bunch of presenters to do the preparation work for me. So most of the work has been done, so I thank you all for that. It's also a great pleasure to be here, so I'm really grateful for this opportunity to talk about this. Okay, so what's the range of my talk? It's going to be from the cardiac arrest stage in the cryopreserved patient or potential cryopreserved patient and to the perfusate cool down. I think in order to do that, I need to talk a little bit about the physiology of death. I want to talk about rescue cardiopulmonary resuscitation, already been mentioned, and its conjunction to torpor. The current use of extracorporeal perfusion with regard to organ preservation, because that for me represents a really good analogue for the chronics patient, and how extracorporeal perfusion may assist in the resuscitation and cool down, which could ultimately lead to post-storage rewarming. I was stimulated to think about this a bit more because I attended the meeting, the Cryo-Swiss meeting in November in Basel, and I was preceded by this gentleman, Dr. Harry Hunziker, who, during his long and excellent talk, made this statement: the chances of cryonics working are 0 to nothing. He also scolded us eventually and said, if you want to increase life expectancy, go work in sub-Saharan Africa and try and increase life expectancy there. I wasn't terribly impressed by those observations. But it is a view that's shared by perhaps 99.9% of the medical profession. I'm starting to meet 1 or 2 people that don't completely share it, so it's not 100%. Okay, so how do we die? This rather colourful graph, if you can call it a graph, identifies the different causes of death as you progress through life, if that's not a contradiction in terms. But despite the fact that you may die from cancer or brain diseases, endocrine infection, it's actually the cardiovascular component that really defines you between being living or dead. So even though it doesn't appear on the death certificate, it's the cardiac arrest that finally terminates you. Okay, so how do we die? The physiology and pathology. I don't want you to take too much into this because this is a kind of an abstract concept. As people go into multi-organ failure, which is what tends to happen at the end of your life, metabolic debt increases and you go into a comatose state, and eventually that leads to a decline that leads to a cardiac arrest and death. Okay, so that's the cardiac arrest point, CA. But actually it probably looks more like this because the metabolic debt that someone is in prior to going into coma, and as they slip into chain stoke, and the agonal phases, the actual stopping of the heart, the final heartbeat, probably doesn't represent such a big difference as one might think. So yes, the heart is stopped and you're declared dead, but it's more of a progression than you may think. Okay, so looking at the thing that enabled you to be declared dead is the heart stopping, ventricular failure. The cardiac surgeons in the room will be very familiar with this kind of graph because although I don't intend to talk about the terrible things that are happening to the heart as it decays, which is on the right-hand side as you view it, I'm looking at the balance between oxygen supply and demand, which once the demand increases beyond supply, things continue to deteriorate, and if there's no intervention takes place, then it leads eventually to the movement into an anaerobic metabolism, lots of toxins produced, and a cardiac arrest resulting in death. So these physiological effects, so nutrient and oxygen supply is stopped at that point. Aerobic metabolism is also ceased, so you're now into anaerobic metabolism, where 19 times more glucose is required to generate one energy than in aerobic metabolism. So the energy stores are depleted rapidly. It's like having batteries running down. So the batteries are running down and can't be recharged. So energy-dependent systems are going to fail and fail quickly. Lactic acid accumulates. Other possibilities will and other elements which are deleterious to the cells also occur, which leads to cell death. Okay, well, we can slow this down with cooling, can't we? That's an easy way of doing it. And if you look at various studies, the effects of brain temperature, when we're in controlled deep hypothermic cardiac arrest using cardiopulmonary bypass, in other words, in surgery where we've had a patient who's been fully perfused and then the surgeon says, okay, we need to stop the circulation, I need to operate on those components where we can't have blood getting in the way. We find that at normal thermia, you've got about up to 7 or 8 minutes before you start to see any brain damage. And as you drop the temperature, then that time increases and you can get down to, at about 18, which is fairly common, you've got about maybe 60, depending on whose data you read. And as you go down a little further still, so maybe an hour. So it's actually not the complete panacea. So let's talk a little bit about this torpor concept, hibernation. And I would like to say it's not just for beautiful people on starships. Okay, torpor for me, it means the active metabolic suppression with minimal decrease in body temperature, so nothing very aggressive, such as black bears do. But this will slow metabolism. It's medically safe down to 30, 32 degrees, helps assist greatly in cerebral protection. Simple techniques to use, cardiopulmonary resuscitation. Anesthetic isn't required, anesthesia is needed. Topical cooling, perhaps chemical induction, as mentioned earlier, such as attacking the adenosine receptors, hydrogen sulfate, although it's only been demonstrated in mice as far as I'm aware. But this may have the ability of, while the batteries are still running down, maybe not quite so fast. Okay, so medical use of this has been reported before. There's plenty now out there, and it's now recommended as part of cardiopulmonary resuscitation, as the previous speaker indicated. It also works in pigs and is shown to be neuroprotective, so that's good. And these temperature ranges we're talking about for modern therapy, 32 to 34, but certainly it's good down to 30, and below that, then things start to get a bit more problematic. For those at the back that can't read the view graph, you're not really supposed to. All I can say is there's lots of bad things that happen when you start to cool people down. Obviously there's advantageous things such as reduced oxygen consumption, reduced carbon dioxide production, reduction in metabolism. This one, the one that interests me probably, is disruption of platelets, so patients tend to bleed. And of course, cardiovascular dysrhythmias, tachycardias, which may not be of any consequence for somebody who's had a cardiac arrest who's in chronics. This is kind of a roadside example. I hope our chronics patient is never in that situation, where you would start the process using rescue CPR in conjunction with torpor. Get them on, if you can't get them on ECMO, then you're going to go through this procedure. You start the cardiac resuscitation of the thumper, intubate and ventilate. The drug protocols, which must include anaesthetic and some sort of anticoagulation, applying the cooling blankets as you see here, and perhaps something a bit more exotic, such as this is showing something called a cool guard, which can cool the blood by the introduction of a catheter into the femoral artery. That's a bit advanced, but the non-invasive rhino chill, which will cool the base of the brain, perhaps has more utility in this situation. Certainly can cool down to 30. before you move to a treatment facility. What happens there? We get them on bypass, get them on, call it cardiopulmonary bypass, call it extracorporeal membrane oxygenation, call it extracorporeal life support, MEC, whatever you want to call it. And there, because if we get them on this kind of machinery, we can restore metabolism. It's surgically safe, as we've seen, down to maybe 10 degrees, cerebral protection, and we get monitoring. We get lots of monitoring, which means that we get control of pressures, blood flow, critical perfusion pressures are maintained, blood gases and biochemistry, fluid exchange, organ recovery and function can be demonstrated. Yes, it's complex to execute, and it's going to require specialist facilities and training, and it's going to add cost. But it will recharge the batteries. So we go from this to a discharged patient's energy stores to recharged. Why is this of any value? In the organ preservation use, the setting of extracorporeal perfusion, the ECP system, the bypass system, can interfere with these processes and negate the effects of ischemia. So it can treat the hypoxic and agonal warm and ischemic periods and restore the circulation before organ removal. And you can demonstrate recovery of function. You can replenish those adenosine nucleotides. You can stop the other processes, including oxygen-free radical production, and which has been demonstrated that you can actually negate the damaging effects of reperfusion. So reperfusion injury, which is a serious consideration. Okay, so it's just recharging those batteries. Okay, so the model that I'm using, the clinical model that I'm using here is the contrast between brain dead donation and circulatory arrest donation. The DBDs were the standard, although circulatory arrest circulatory death was also used, but not so much. But over the past few years, those have become increasingly important. The problem is that no matter what care you take in selecting your DCD donor, that it translates into poorer outcomes for those organs compared to brain dead organs recovered, and also an increased risk of retransplantation and death. So they're not as good. However, you can improve them with the use of cardiopulmonary technology. You can bring them back up to the standard, if not better than the brain dead donor organs. Okay, cardiopulmonary bypass can be quite complex, or it can be quite simple. So that's an ECMO circuit that we designed for just such a use, and that's how primitive it looked. And this was in 2011 for putting donors on bypass in order to resuscitate them and then recover their organs. It's a technique that was pioneered in Spain, so thank you very much for that. Okay, but also there's machine perfusion. Usually machine perfusion doesn't mean an extracorporeal bypass, although that's a MEC. It's more to do with taking individual organs, hearts, lungs, and putting them on an extracorporeal circulation system. It's a transmedics for hearts, but it can be used for other organs. This one's an organox. I had some dealings with the actual designer of that one, so I quite like that one. And the organ assist, that happens to be for liver, although there are other flavours, if you will. Okay, so these have a major benefit in these organs. So I can say that machine improvements does improve the outcomes for DCD. So there's no reason why this idea should not improve the outcomes for the potential chronic patient. So for them, clearly, once we get them back, we need to establish some sort of bypass. We need to rewarm them. Rewarm them? We need to rewarm them. Why? Because we want to normalise biochemistry. 2 to 4 hours, perhaps. We want to recharge those energy stores, and that really only works at normal temperatures. And once we've achieved that, then we can commence cooling, perhaps lower hemoglobin, although quite a lot of these patients do tend to be quite anemic. and at whatever temperature is deemed suitable, convert to the cryonics fluids and protocols, and with the possibility of then introducing perhaps iron oxide nanoparticles in that perfusion, as this has been shown at least to work in small, or up to about 50 grams worth of tissue. The problem with tissue, even single cells in liquid nitrogen temperatures, less than 70% will survive the rewarming. The possibility that we can use the cryopreservation to as implanted at the beginning, so that we can then introduce inductive heating, offers, I think, some interesting prospects for the cryonics patient. And although it's a relatively new idea, I think it's something that's worth exploring. Clearly, the way that it's done currently is quite primitive. Maximum of 50 grams, 50 mils of cells, and essentially you'd need to upscale it to get it to a single organ or even a whole body. We're certainly going to have to do better than just popping it into the nanoparticles and then in the liquid nitrogen and hope for the best. So active perfusion may be the way forward. So in summary, how we die, it's the loss of energy stores that's important. Torpor and mild clinical hypothermia can perhaps slow those energy store loss. Active perfusion, we can see it's been used successfully to improve organs following circulatory death. And so that bypass as well can help to replenish those stores systemically for the entire patient. And could be an ideal way, don't know, could be an ideal way to infuse magnetic nanoparticles, which may facilitate the inductive warming of magnetic inductive warming of the cryonics patient post-storage. But however, a truly robust cryonics is likely to be complex and expensive. So my answer to this gentleman, maybe the chances for cryonics working are no longer 0 to nothing. And we can increase life expectancy for in sub-Saharan Africa, who knows, 45 years to infinity. It's just going to take a little longer. Okay, that's me trying to do that sort of thing in the third world. It makes so little difference. I don't really think it's a good way of spending your time, to be honest with you. It helps the individuals, but the population, nah. Anyway, thank you very much for your attention.